the board. Okay, Dr. Nario, you are on. This is Chronic Disease Prevention Management weekly webinars, the CME, credited from American Medical Association. I don't know if you put the first page where it shows all the disclosure and I think it's category 1 to hopefully 2 hours. And you're gonna talk about estrogen detoxification and all the protocols related to that, right? So, Dr. Nario, the mic is yours.
All right. Okay, thank you, Dr. Halassa. So let me just share screen here. All right, is that better?
Yes, we're good.
All right, so yeah, well, welcome everyone. Thank you for having me. Thank you for watching this lecture. Hopefully I can give you a better and deeper understanding of one of our favorite hormones, especially in hormone replacement therapy realm, which is also one of the most misunderstood in relation to its health benefits, estrogen. And this has been a discussion here at CDPM.
Melvin, hold on. I can't hear you. Is everybody having this problem? I cannot hear. He's coming in.
Yes, I'm having echo. It too.
Hello, hello.
Got
That's
microphone problems. There you go.
Hello, hello.
Better.
Better.
Count to 10.
1, 2, 3, 4, 5.
No, you're getting intermittent transmission, 2 seconds on, 2 seconds off.
How can I prevent that?
Do you have a microphone you can use?
Let me see.
Try to unplug and replug it in. Sometimes that helps.
Let me try a mic here.
Yeah, you're coming in and out.
Hello? Hello?
Good.
Mic
Sounds a little
test. 1, 2, 3. Is that better?
It's better.
Okay. Yes, so this is in line with our recent conversations, Dr. Halas's and Joseph's presentations of hormones in our platform. So just to give light and a little bit more specificity about our known estrogens here. And some of you actually have heard this, and I revised it and updated this literature that we have here. And again, we will discuss this in the view of urine metabolism test, since there are different ways to assess for estrogen. Others are blood and saliva. I won't be endorsing any company because this is CME, I guess, credited. But the common ones are out there, and we can probably talk about that maybe after the lecture. Again, no disclosures. I don't have anything. I'm not selling anything. I'm not affiliated with anything at all. And because of us having a CME accreditation, here are our learning objectives for today, and 3 basic ones. And you'll see this as we go along. And here are my credentials. Before I start, I just want to thank Dr. Halassa, CDPM, for his invitation, and of course my mentors, Dr. Cora, Dr. Forsyth, Dr. Clearfield, Dr. Majid, my biointegrative health staff, especially Lucy and Carrie, my left and right arm. What would I do without you guys? All right. All right, so let's start. So I also want to, again, thank my mentors in the faculty in A4M. This is where it all started, where I got introduced to BHRT, Dr. Sudan, Tara Scott, Sarah Gottfried, and Dr. Trindade, who shared their knowledge to me in this special topic. Well, it was sounding like a radio station here just for shout outs, but let's move on into our discussion. So when I started my career, I only wanted to treat men's health. Why? Because I can relate better. Male doc equals male patient. I was thinking of testosterone therapy, anti-aging, stamina, muscle building, etc. I only wanted to treat this guy, and yes, even that guy. But suddenly I realized we have numerous women showing up in my practice who are perimenopausal, menopausal, who has fatigue, moodiness, hot flash. Of course, I cannot reject them. So what do? You adapt to learn how to treat them. Helped by my mentors, the fellowship, training in A4M, as I listened to my patients, I entered into the realm of BHRT for women. I'm not going to discuss all hormones involved in BHRT, but we'll discuss the most dynamic one of all, which is estrogen. What is it, different types, and how do we detoxify and regulate them? So estrogen facts here in BHRT, we all know about the most common hormones involved, which are estrogen, progesterone, testosterone, and cortisol. Excuse me, there will be moments that I will be using these letters to pertain to these hormones. Today, we'll focus on the most dynamic one of all, at least for me, due to its function in various forms, which is estrogen. Best way to understand it is to quote the Endocrinology Bible, which every OB-GYN knows about. And this is the Spearoff book of clinical gynecological endocrinology and infertility. As defined here, estrogen is, as you would see, so many different definitions. One in luteal phase, specifically made in day 1 to 14. For regular cyclers, and always remember, this is day 1 is the actual start of bleeding and of consistent flow, leading to a thicker endometrial lining. Number 2, the cause it causes growth, especially breast, uterus, ovaries, specifically when alpha receptors are stimulated, leading to proliferation or growth. I'll explain these receptors a little bit. And then 3, when estrogen is mentioned, we always need to know progesterone. Progesterone provides balance to estrogen action. Reason why we usually give progesterone doing BHRT along with estrogen. Sorry. Usually if estrogen is unopposed, it can lead to reproductive cancers via cancer cell activation. Facts number 2, or slide 2, stimulation of estrogen can occur in both breast and endometrium due to the presence of estrogen receptors. Remember, there are 2 types of estrogen receptors, and they are alpha, which is stimulatory, beta, which is inhibitory. And third, progesterone is protective due to its inhibitory properties and used in balancing when using estrogen, especially in breast health. And also, of course, uterine and other organs like ovarian as well. This is nice to know. Number 4, the statement is questioning if tamoxifen really works. It is used to block the actions of estrogen in premenopausal breast cancer. But when estradiol, again, is compared here, estradiol is this strong, as you would see here, how much the difference would be in relation to the affinity to receptors. So how can tamoxifen bind properly to do its work? If you could see estradiol is much higher. Makes you think, right? Okay, NAMS, this is one of the authorities in relation to women's health. Let's hear what the major societies have to say about estrogen along with their recommendations. One, you can tell that they are still citing in the unopposed estrogen prescribing in HRT. As we all know that with or without uterus, usually use of estrogen with progesterone always should be advised for protection. Vaginal estrogen is okay, but I prefer DHEA due to faster acting and just needing to apply on the outer area of the vaginal canal to be effective. Not outside, but on the outer canal, it's still inside. Second would be, I agree with the vaginal estrogen or DHEA for vaginal dryness. Remember, vaginal estrogen can also be used in menopause with recurrent UTIs, not only for dyspareunia. Third, when you hear synthetic hormones, part of that is equine or horse. We are not horses, you have to remember, and we don't run the Kentucky Derby. Reason why? It produces too strong of a receptor stimulation. And next would be probably not a good idea to just use estrogen for long durations without progesterone. If they are saying that estrogen use has low risk of breast cancer, it might even lead to a lower risk when you use it with progesterone. Better outcomes, right? Then hot flash indication only is what FDA approves for hormone therapy. But many indications, which are long-term benefits, such as bone, brain, cardiovascular health, are still unacknowledged. And then next slide would be, why is it still unclear that hormone therapy is still questioned in relation to the improvement of the quality of life, even in asymptomatic women? Would they be happier if they realize that they are preventing strokes, heart attacks, and even osteoporosis in the future? I would. The use of HRT does increase the risk of CVD and breast cancer. If it's unmonitored use, meaning if there is no testing or preventative screening that is being done to assess how they are working in the body. Reason why we as practitioners should be educated to protect our patients and making sure that they are safe to use HRT even after the 10-year window over menopause. And again, synthetic, bioidentical, these are things that we have to consider there. All of these statements can be found in the NAM's website. Now let's go to the Endocrine Society, and also you can find all of these as well in their website. As seen here, that small estrogen dose intravaginally is allowed and safe and has proven not to be in the systemic circulation to affect breast cancer. Even ongoing treatments or even a personal history of, as underlined there, very important in patients who needs care with these special circumstances or needs. As educated clinicians guided by evidence-based guidelines, we can address our patients' needs without being scared or afraid of doing harm. It's a different story for high doses of estrogen intravaginal. Regular dose of vaginal estrogen, initial dose would be around 2 to 4 grams once a day for 1 to 2 weeks. Then gradually reduce dose by half. The goal is to restore vaginal mucosa here. And maintenance would be 1 gram intravaginally 1 to 3 times a week. Anything more can become systemic, thus the worry about estrogen receptor stimulation, specifically, of course, alpha. Even with the WHI, the study that gave hormones a bad rep, acknowledges the strength of equine hormones on how they are unpredictable in terms of their effect. Speaking of the devil, here it is, WHI. Let's just revisit what this study revealed in relation to the reputation it brought to HRT. Highlights here are CEE and MPA, or estrogen and synthetic progesterone. These are non-bioidentical. When you hear this, you know it's trouble brewing. They were used in cardiovascular complications and breast cancer outcomes were the ones heard by everyone in this study to start fear in hormone use. So let's break it down quickly on why it is flawed. 1, the sample age range. What do you expect when your subjects are 63 and above? More cardiovascular risk and comorbidities. HRT, when started early, is more beneficial, especially in the perimenopausal period. Next one would be oral conjugated equine estrogen. We are not horses, you have to remember. And stimulation, of course, happens directly to the alpha receptors, which we don't want. And then third would be synthetic use of progestins and progestogens versus bioidentical progesterone, which is safer. And we repeat this over and over here in CDPM about the use of bioidentical versus synthetic. All of these factors equals disaster. Nurse-to-cell study, let's now add more evidence-based weapons to support the use of estrogen safely in our toolbox. 1, NHS here showed evidence against the WHI where estrogen is cardioprotective, while WHI showed 7 heart attacks in terms of their study, in terms of incidence. And more weapons here. 1 and 2, oral CEE used is more of a clot former, but not transdermal. So oral, always kind of no. And then third, benefit of transdermal estrogen is more than CEE in the arousal realm. All right, yowza. Even in the Lancet, the prestigious medical journal, chimes in and is rooting for estrogen. Well, the final nail in the coffin, one of the bigger evidence, this proves that even horse estrogen alone can be less harmful versus synthetic estrogen and progesterone or progestins, making our suspect being more the synthetic progesterone known as progestins/progestogens that can be doing the damage. Am I done? Not yet. One last here, even JAMA gives their thumbs up on estrogen in this headline. Let us not fear estrogen itself, but fear on how we use it and its metabolism. Using it wisely, lesson here is it's not about having a sword or a weapon that is the problem. But the problem is how you use it. It can either cut your hands if you're klutzy, or it can protect you from your enemies if you know how to use it right away. I don't know who uses a sword nowadays, but you get what I'm saying. Here it is. Here's the stereogenic pathway. Looks intimidating, I know. You will see on the bottom our target of discussion, which is only estrogen metabolism. In my opinion, this is another aspect of other than just understanding what E1, E2, and E3 are. We should be worried about how they are metabolized and used inside the body. Well, let's first define our cast of characters here. E3, good angel. E2, stuck in the middle, can turn into bad or good. E1, evil, always up to no good, right? I will use a common urine test panel that I use in my practice to understand the pathways of my patients. If interested, you can contact me later about it. When I started, I thought that knowing what E1 to E3 was enough for me to manage BHRT and women's health. But as I studied this more, I realized that I was only scratching the surface. This concept of estrogen metabolism is needed for me to give proper and thorough care for my patients. Forms of estrogen. Always bear in mind the receptor effects in relation to estrogen function. Alpha promotes, beta inhibits. E1 is, of course, the bad due to more alpha stimulation, is actually a weak estrogen with only about 1/5 the binding affinity as E2. It increases the risk of developing breast cancer, though to be related to endocrine disruptors as well, like BPA, as BPA likes to stay in fat, which is adipose, and as we all know, a source of E1 as shown. E2, the ugly, the most potent estrogen out there, it's stuck in the middle. It can turn into bad or good. It has equal receptor stimulation. And during reproductive years, it's the most prominent due to the ovarian production, from ovarian production. E3, which is good, a weak estrogen with tissue selective activity in the lower reproductive tract, birth canal. Why related to pregnancy? And why we like this is due to its prominent ER beta dominant stimulation. Well, another good way to understand this process, if you have two children, you gave them money and you want to know how they will use it. One child went out partying and spent all his money on booze, and one child gave his money, saved his money and put it in the piggy bank for college. I don't know how much they can save in a piggy bank nowadays. But if you use estrogen and BHRT protocols, if you create more bad estrogens called 4-OHE, then you do more harm. If you create more good called 2-OHE, then you're more protected. More about these terms in a bit. So these are our paths of detoxification. We have now established E1 is the bad estrogen. Even called as such, our body still has a way to save us from its bad effects. Let's talk about the different roads where we will dispose and manage estrogen. As we encounter various external toxins, usually they are fat soluble. They are all filtered through the liver. Phase 1 involves cytochrome P450 enzymes in the liver. Tricky part is phase 2 needs to act on these partially processed toxins due to them being reactive or still actively considered toxic. Reason why phase 2 conjugation reactions should always be made sure to be working. After phase 2, as compounds are now safe to eliminate in water-soluble form, in phase 3, elimination, usually from the gut, finishes the job. That is what we always refer to in practice as detox. I'm sure many products have been encountered in our practices claiming to detoxify, herbs, colon cleanses, diuretic, etc. This is the process that is involved in all of these. So phases of metabolism, this is the overview process on how unused estrogen is primarily metabolized in the liver via phase 1 and phase 2 detoxification, and in the gut for phase 3. We will go through this as we go along with the discussion. Out of all phase 2 processes, important in 2 processes, important in estrogen metabolism are methylation and glutathione pathways. Always remember the statement on the bottom. Occurs physiologically in numeric order. Phase 1, 2, and 3 should be addressed in reverse order. 3, 2, and 1. And this is important for this shows us the process happening in our body and how we will manage this in our patients. SNPs, single nucleotide polymorphisms. What can affect these detox pathways to go wrong are these guys. Phase 1 and 2 are influenced by gene structure and alterations. We call them SNPs. And these are substitutions of single nucleotides of specific positions in the genome, leading to alteration in function of the enzyme. Worst is to have homozygous, meaning 2 abnormal genes, heterozygous, meaning 1 abnormal gene. Usually this is more intricate than that, but let's establish this basic knowledge for today's discussion. So phase 1 detox involving CYP1B1, 1A1, and 3A4. Here's a famous urine metabolite test that we use in our practices when we say SNPs or single nucleotide polymorphisms in phase 1, the ones encircled here in the diagram, it always leads to upregulation, meaning faster functioning or faster process. Phase 2 detoxification, methylation, and glutathione SNPs in this phase 2, which are encircled, leads to down regulation or lower functioning. Emphasis again, only in estrogen metabolism is our methylation and the glutathione pathways. As an example, SNPs happening in the CYP3A4 here, you would see it leads to more 16-OH. And I'll explain this in a bit as we move forward to other slides. Usually high when there is high environmental endocrine disruptors like BPA, PCBs. So this is just showing you how the result is when that SNP is affected. Okay, so always remember phase 1 related to CYP450 enzymes, phase 2 related to COMT and glutathione pathways. So when it's when there's a phase 1 SNP, there's an increase in enzyme activity. When the phase 2 SNP decreases enzyme activity. So here, the SNP for a CYP1A1, let's start with the pathway for production of the good estrogen, which is the protective pathway. Enzymes involved here in phase 1 is CYP1A1, leading to the production of more 2-OHE1. So you would see that on the bottom here as you go down. So let's move forward to 2-OHE1 here. Even though even though it's not methylated yet, so you would see that, so it hasn't reached that methylation pathway yet. Already, it has a good benefit. It has slight protection towards breast cancer, according to the literature. Not enough, though. We still need to push it to methylated to be more protective from 4-OH. Again, I'll explain 4-OH soon, to give you an idea of what that is. But you would see here, we need to push it farther to get it to be methylated towards that L part of this, reverse L part of this diagram. And as 2-OHE1 gets methylated by COMT, which also you saw on the here, COMT methylation, to methoxyestrogens, which has now therapeutic use in breast cancer and even cardiovascular disease. This is where we want to be, as you can see here cited. And remember, polymorphisms are associated with reduction of enzyme activity. If lowered action of COMT leads to lower production of protective 2-methoxy-OH. and more risk for cancer. Later, you will see how 2-methoxy-OH acts as a buffer to prevent 4-OH in doing its damage. So SNP for CYP1B1, let's talk about the path that we want to avoid here. That's why it's colored red, which indicates the red line, meaning danger. CYP1B1, if upregulated, leads to cancer-forming estrogen. Polymorphisms is associated with a faster enzyme activity, leading to increased 4-OH, which is carcinogenic, as you can see here cited, not only for breast cancer, but also for other reproductive cancers, endometrium, ovarian, and as you can see here, according to the biochemical molecular biology. This is the bad boy of the show that we need to prevent. Very potent tissue stimulator, and not only for female reproductive organs, but also for men. Thus, reason to check this as well in men's health. And DNA adducts, these are formed from 4-OH, are covalent modifications of the DNA that results from exposure to specific carcinogens, in short, DNA damage. And thus, the level of DNA adducts in normal cells can serve as a biomarker for a significant exposure to carcinogens. Are you wondering where our favorite horsey estrogen does its damage? Here it is. Why it's carcinogenic? Because it promotes more 4-OH production. Who will save us from this enemy? Nobody else but Super D. D for detox. 2 paths to utilize to neutralize 4-OH, as I mentioned a while ago. The methylation and glutathione pathways to divert it away from reaching the DNA. The bigger challenges is in not activating these pathways could be SNPs, and this is MTHFR deficiency. If 4-OH is not inactivated by COMP related to methylene tetrahydrofolate reductase enzyme responsible for the production of 5-MTHF, 4-OHE1 can be oxidized to quinones compounds that will attack your DNA. What did we say about phase 2 detox SNPs? Always downregulated processes. Worse SNP, when you analyze MTHFRs, would be the C677. Milder defect is the A12. We can see how it contributes to cancer even with a milder defect, whereas this homozygous is worse, as I mentioned a while ago. Thus, we should be checking. This can be initially be ordered in a regular lab test. And if you want complex testing on this, the specialized labs or the functional labs that we have also offers that. The other arm is the glutathione pathway. If you do a genetic test, a specialized test, these are the results that you will see. Absent, more aggressive replacement and supplementation of glutathione to help you detox, or one of our favorites, NAC, is here as well. If present, we still want to be supportive regardless. So CYP1A1, if you think about it, is it good to have a CYP1A1 SNP so it can just supply the body with protective estrogen, which is the 2-OH? Now understanding both 2-OH path and 4-OH path on how they work, we can now understand CYP1A1 better. Remember, if there is a phase 1 SNP, again, as I repeat it over and over again, it will be upregulated. Increased 2-OHE1, which is still unmethylated, you have to remember, and not ideal for cancer protection because we want it to be still methylated. Reason why we need more of the methylated to protect us from the 4-OH load. This is how a C1A1 SNP contributes to the worsening condition of an increasing 4-OH load. Again, here's the evidence in our literature. Not forgetting 16-OH, as I mentioned again in previous slides on literature, it is still considered an estrogen receptor stimulator, though not as strong as 4-OHE1, but I still consider it to be worth lowering down. And this is a specialty of Dr. Patel, special mention here about endocrine disruptors. that can modify intracellular communications and functions found in our favorite detergents, for perfumes, plastic bottles, cleaning agents. Pathologies are produced mostly by affecting phase 1. They affect hormonal balance, metabolic, and cancer activity. When all else fails, you don't understand this part of the lecture because of all of the medical hullabaloo and jargon, look at this colorful pie graph in the test that shows like a summary of everything. The main objective here is put all of these numbers into the normal ranges for a proper estrogen metabolism process to occur for the patient. And as we move on, to remind us where we are in the process, we just discussed phase 1 and 2 and how estrogen gets metabolized. And now let's go to phase 3. Always remember, and I cannot overly emphasize this, I'm knocking on the door of your frontal cortex. Let me in with this message. Of course, physiologically, phase 1, 2, 3, and then you should address this in reverse order, 3, 2, 1. So elimination. The gut is the factory that will package estrogen out to, of course, not so that it would not accumulate in the system and dispose of it properly. We have to have a good gut workers to do this. We need bile, a good microbiome, and of course, less inflammation, everything all playing in combination. We have tons of workers in the gut. We have good, the bad workers, of course, meaning rich diversity. They have groups like unions and circles of friends, which are what we call the phyla. Not only are they doing one thing, they're always known for digestion, but multitaskers, as I mentioned above, to prove that they are multisystemic in function. Reasons why we need to make sure that they're always happy. Here is the, the party that is going on in the gut, to give you an idea. A sample of a common stool test that we do use in clinically to assess the microbiome diversity, as we call it. Well, let's be specific now about the part of the microbiome that deals with the body's circulating estrogen, which is called the estrobolome. They distribute estrogen in the body for its systemic effects. A lifetime exposure to estrogen causes greater microbial damage. Thus, they regulate just the right amount the body needs. If we have the right balance in the estrobolome, it was seen that its capacity in hormone regulation can be comparable to a prepubescent microbiome. Complete again, higher short-chain fatty acid production. And as we all know, SCFA is food for our enterocytes and the microbiome. Overall, a happy gut, happy hormones. All right, disruptions of the microbiome. You would notice here different factors, but let me just run it down quickly. The mouth of the baby, as it passes through the vaginal canal, inoculating it with vaginal flora. That's why we always, as we prefer, normal spontaneous delivery. And then bottled breastfeeding, of course, breast milk, a microbiome inoculates the baby's gut. And with antibiotic use, as a good example here would be chronic Lyme patients who are given multiple and chronic fashions or bouts of antibiotics. They're like nuclear bombs in the gut to create destruction. And chronic stress, how we belittle stress, actually leads to sympathetic response, which leads lower blood flow to our guts, leading to possible constipation, for example, and also low blood supply for our microbiome. And steroids, even inhaled steroids has the evidence that it disrupts the microbiome, not only IV or oral. And our chosen food, I guess, sensitivities like gluten and dairy are common allergen sources that we should avoid. And who wouldn't know about the SAD diet, right? The frowny face stands for the standard American diet. People think we always need more protein. People want meat for muscle, but instead we are lacking in our daily fiber intake as a whole nation. And our diets, we lack in color. So fries and burgers doesn't bring color as far as I know. And of course, lack of exercise, unless pushing the remote and putting chips in your mouth is exercise, then majority of the population are all fit, right? And circadian rhythms are always disrupted, and eating foreign food during travels actually leads to many gut reactions. And then also mold, we have spoken about that topic here multiple times. And a big factor there is in mold illness, you have low melanocyte stimulating hormone, or MSH, which is a big factor why tight junctions in our gut are tightly knit. And low MSH leads to disruption of the gut barrier. Poor sleep actually leads to shedding of the gut lining and also less microbiome diversity. This is the phenomenon everyone is describing as leaky gut. As the barrier is broken, now foreign substances can now get in the circulation to create inflammation. These two above are the major effects in estrogen metabolism. In general, intestinal permeability leads to systemic inflammation, leading to suppression of ovarian hormone production and growth of unwanted bacteria to increase unconjugated estrogen back into the circulation. So you would see here highlighted high beta-glucuronidase and hormonal affectation. So UDP, glucuronyl transferases, let's stick with UGT, that's a pretty long word, enzymes binds to drugs, xenobiotics, and estrogens. They play an important part of phase 2, detoxification, then connects to phase 3, detox. Toxins and hormones are bound to glucuronic acid to turn them to water soluble. So mechanism that is to protect for the body after liver processing it will be delivered into the gut, where it may be interacting with the beta-glucuronidase. Phase 3 starts when estrogen, sorry. Phase 3 starts when estrogen is transported to the gut. So you would notice here as it travels the outside lining of the gut, it's conjugated estrogen. But as they encounter the bad bacteria that we have that spits out beta-glucuronidase, it now splits these molecules and reabsorbs these estrogens that were about to go out. And they are now bringing it back into the system, thus causing estrogen dominance, of course, bad stimulation of the alpha receptors. And yeah, most estrogen should exit the body. You have to remember via colon with the beta-glucuronidase, some will be excreted and some recirculated. And this is what happens when high beta-glucuronidase will be noted on testing. So that's why this is very important. And we will see this a lot if we do the proper testing. So when I mentioned about proper testing, here's the test that we always commonly see in our clinical practices. And the way to test this is via stool samples. High levels not desirable due to correlation of higher recirculating estrogen. And one question that I always get from patients, what if it's low? Lower levels, not much to be worried about, according to the literature. So symptoms of, look at this, elevated beta-glucuronidase. So what do they all look like? Heavy periods, clotting, cramping, fibrocystic breasts, headaches, mood swings, fatigue, brain fog, infertility, and weight gain. They're similar to estrogen dominance. So they're basically the same entity. The time to treat, though in reverse, remember what I'm always reminding you of, I'm beating it into you like a drum. It occurs physiologically in numeric order, 1, 2, 3 phases, but should be addressed in reverse order, 3, 2, and 1. So rebalancing the microbiome, the main goal here is to move the gut, normalize that beta-glucuronidase. And fiber, as we can see, this is the biggest deficiency of our nation, and not protein, not meat. Fiber supports healthy microbial balance. Here is the proper distribution, as seen above, 55% insoluble, 45% soluble fiber. And just to define soluble fiber, fiber that dissolves in water, forms like a gel-like substance, leading to a slower digestion and promoting absorption. Examples of this would be lentils, nuts, oats, and certain fruits, and even vegetables. And for insoluble fiber, meaning the fiber that does not dissolve in water, but helps food move through the digestive tract at a quicker rate. They don't dissolve, thus it adds bulk forming to the stool and even a laxative effect. That's why it's good for constipation. And examples of this would be common vegetables and whole grains. And lignins, what are lignins? Lignins are structural materials in the support tissues of most plants. Lignins are particularly important in the formation of cell walls. And also, we need more color in our food. These are the phytonutrients, the antioxidants. And eat, as we always remember, eat according to the color of the rainbow. That's a pretty good guide for us to follow. And let's add some spices like curcumin. Though even with poor oral bioavailability, it actually promotes diversity in the microbiome when it's in the gut. But I'm not really worried about curcumin. I tell my patients to kind of, hey, take as much as you can just because it's not well absorbed. And I've been hearing about cyclodextrin, liposomal. There's still many ways to enhance curcumin absorption now. But again, that's to be determined. But you can go crazy in curcumin as much as you want on my end. And then FDA notes milk, wheat, and soy as top allergens, meaning gut inflammation. And then should always, not always, but the ones who are sensitive should be avoiding this. And then probiotics, Lactis acidophilus, Bifidobacterium lactis, are known for beta-glucuronidase deactivation for healthy estrogen metabolism. So it's not only calcium D-glucarate that is the remedy for that, but you can also use these specific probiotics to negate a high beta-glucuronidase activity. And then, of course, rebalancing the microbiome here, disrupted circadian rhythms. As always, we are people who are so used to like watching TV before going to bed, playing with a phone. It disrupts the microbiome and as well as hormones. And 30 minutes per day, at least for exercise to increase heart rate and sweating. Exercise had shown increased butyrate production and reduction of pro-inflammatory cytokines and oxidative stress in the gut. Vitamin D, zinc, C, and quercetin, we have encountered these supplements during the times of COVID. A healthy immune response keeps inflammation down and supports hormone production. The vitamins B6, folic acid, B12, and even choline promote bile synthesis and efficiently bundles toxins up and estrogen metabolites for removal from the body by the gut. And lessen stress effects. And constant fight, flight, or freeze quickly disrupts the microbiome. I know, easier said than done, but that's where we discuss to our patients box breathing, meditation, yoga, tai chi, and all of these body, mind, spirit activities. For phase 2, we talk about methylation. As you could see here, how the COMT pathway is involved. And our methylation supports here, maintaining CME availability would encourage COMT activity. Methionine, especially important if there is low homocysteine. So we don't only treat high homocysteine with Bs, but even low with methionine. Very rare to see though, but just a fun fact, maybe even trivial. Because for me, I have not seen much of this low homocysteine. And here is our usual supplement supporting cast for methylation: magnesium, B12, B6, and folic acid, but in the form of folinic acid or methylated forms like methyl THF and tetramethylglycine or betaine. Phase 2, glutathione detox. So our common glutathione supports. So reduce glutathione 1 to 3 grams per day. You will hear also liposomal. Again, the cyclodextrin delivery. There's also one out there, IV versions, of course. And then for NAC, the one that we always hear in our discussions, which is a glutathione precursor, 600 to 3,000 milligrams a day. Lipoic acid, around 200 to 1,000 milligrams per day. Whey protein concentrates, 2 to 3 servings per day. magnesium 400 milligrams for a minimum. So I have a way of telling my patients how to use magnesium. So I actually use up to bowel tolerance. Of course, you need to keep an eye on kidney functions here because you don't want to get, of course, arrhythmias. If you have high magnesium stuck in the system, that will lead to. But again, yeah, 400 milligrams is a good way to start. But bowel tolerance is also something that you can do. And I like the types of oxide citrates. They're pretty okay, but anything higher than that is okay for me, like threonate, taurate, or even glycinate. Vitamin C, a minimum of 500 milligrams, and you can go higher, but also keep an eye out for how much a gut can take, because diarrhea and GI irritation, you would know that as you move forward. I use this also for like detoxification or just people who also has bad bowel movements or constipation. Vitamin E, 400 international units. Silymarin, 400 to 1200 milligrams per day. Pantothenic acid of 500 to 1000 milligrams per day. And CME, 400 to 800 milligrams per day. Caution on CME, in my clinical experience, it actually sometimes when you're a new user, brain stimulation usually is seen at the start, but your body gets used to it and eventually goes away. And also the 3 amino acids producing glutathione, which is glutamate, glycine, and cysteine. And on the bottom, riboflavin and selenin. Modulators of the CYP450 enzymes, purple grapes with resveratrol. It actually blocks dioxin induction via aryl hydrocarbon receptor. Berries, they carry a lot of this as well. And EGCG in green tea. So these are the common ones that I use in my practice. And in my years of practice, I always have thought that giving DIM or I3C in a hormonal imbalanced female is beneficial. So when I teach students in A4M about this is the common mistake that everybody does. So I just want to like go through it over and over again for clinicians to understand, thinking that DIM and I3C is fixing all the metabolism issues that there is, or meaning estrogen metabolism problems, until I got taught, of course, by the fellowship that it can be a double-edged sword. So if you have to pick one lesson here in my lecture out of all the information overload that I gave, is this: don't start all hormonal female cases with these two remedies or herbs without checking metabolism. How can it hurt? As the literature above states, I3C or DIM can increase CYP1B1 activity. As it pushes the red arrow further down 4OH, it will accelerate the formation of bad 4OH, especially if your glutathione and methylation detox pathways are not fixed, to divert it away from creating more of the DNA adducts. This is the reason why fixing phase 3 to 1 should be done before giving DIM or I3C. And also indications of use of estrogen metabolism testing, which is the urine metabolism testing that I'm pertaining to. A few reasons why I assess this in my patients, and I'm sure there are more, but this is in my clinical experience. I use it on women with adenomyoses, endometriosis, even ovarian cysts, fibroids. Question in my head is, why are they forming these? Are these pathologies in the estrogen metabolism usage that we need to uncover? Data shows that there are phase 1 and 2 abnormalities that are involved in these problems. Another indication is for patients who are on hormone therapy. If they're using the hormones the right way, if you're intrigued by that and you want to understand how they're metabolizing it, and patients with high risk possibilities of developing breast cancer, like BRCA1 positive patients, and also for breast lumps, cysts, and fibrocystic changes while on hormone therapy. And change of malignancy transformation or development can be all considered as well. Or even while on BHRT, as I mentioned, if E dose is, if you were intrigued in if the estrogen dose that you're giving the patient is causing bad stimulation. And the most important, prominent right now in my case as a clinician because I see cancer a lot in the cancer center, are all post breast cancer interventions for people or patients who went through chemotherapy, surgery, radiation. The mentioned managements are good, right? In removing the symptoms of cancer. And then to follow up with an estrogen metabolism test, we'll now look out for the root cause that why did the body have such cancer in the first place? And surprise, men too. Wait, we are not done yet. And when we thought women are the only ones who can benefit from this test, we are wrong. Men as well, we usually point our finger on testosterone to be responsible for prostate cancer growth. This is evidence why the conventional medicine is using Lupron, which is a GnRH agonist to lower testosterone in prostate cancer. Dr. Morgenthaler backs up the theory that testosterone is not the culprit to aggravate prostate cancer to justify this test. This is now also evidence that a high 4OH, which is estrogen, bad estrogen pathway, contributes to the promotion of prostate cancer. So men, beware. I want to dedicate this lecture to my father, who's also a Dr. Benjamin, who inspired me to be a physician and to be a man for others. So thank you, Dad. He's up in heaven now, and I love you. Question, comments, and feedback, and yes, even complaints, please contact me. With all my heart and gratitude, I want to thank you all for taking the time learning from my lecture, and hopefully I have given the gift of education to you in helping your patients achieve better health. Thank you, and God bless.
Thank you very much, Dr. Nario. I mean, the presentation was excellent.
Thank you.
Super excellent. Because, you know, you come up with the logician way of explaining and breaking down and showing all the chemistry and mechanism of action while you are presenting your lecture. And that's very important, is that reasoning and logic, and because it helps us to process the information better, and it helps us when we know the reasons and the logic behind every steps, then we can easily combine things and make sense out of creating protocols. You know, creating protocols without knowing the mechanism of action of the ingredients is not favorable, because it ends up with conflicts between those ingredients. But understanding why we're combining, and combining it is better than mono, and the steps as well, you know, making sure you detox the body before giving them. And I think it's just I mean, the presentation was just excellent. I just want to add something here to the good news, is that before, we don't have anything that will detox fat soluble toxins, that would detox those extra cholesterol in the body that's been deposited in the blood vessels, that we don't have, especially oxidized LDL, that we don't have anything to detox the mycotoxins, that we don't have anything that detox those endocrine disruptors, which are the plastics, all those fat soluble petrochemicals, organophosphorus. And now we have, which is something called cyclodextrin. And I would like to thank Dr. Klantz for bringing it up, because it helped him with his health and managing his own atherosclerosis. And then I start digging more, and I see the mechanism that it's similar to a high density lipoprotein, where it has a core that's hydrophobic and exterior, which is hydrophilic. And so it can collect all those extra xenoestrogens and endocrine disruptors, those plastic and petrochemicals that is being deposited in our tissues. And then it get rid from it through the liver, and it secreted the bile. And yes, if you want to add cholestyramine, you know, along with it, that's something complex with cholestyramine, and then make sure it will not be reabsorbed again. But that's something I want to discuss it, and we have a lecture on that with next week with Dr. William Bill. But meanwhile, I mean, your presentation is great. It's missing the iodine. Yeah, I wish if you add the iodine and the importance of iodine, which has come from Dr. Stipa, that helps to convert the estrogens to estriols, and that's very critical part. But other than that, your lecture is complete, comprehensive, to the point, and the understanding of combining progesterone and estrogen is critical. Of progesterone with testosterone and balancing, even vaginal estrogen. If the patient already is having risk, let's say the polycystic ovarian syndrome, and then you give them vaginal estrogen, you want to make sure you add progesterone. There will be no harm there because progesterone will maturate the epithelium. And estrogen is proliferation. Yes, it will help to increase the thickness of the vagina. That's what you need. But also you want the maturation to go. I don't think there's a harm to add progesterone with estrogen gel. Is any harm with that? Why you are saying just estrogen instead of combining it with progesterone?
No, not really, because I do have patients who does also progesterone intravaginally, but majority of the time I have a lot of patients falling off from that, just because they don't like the feeling of putting a lot of creams down there. But there are studies that vaginal progesterone also has the ability to protect your uterus. So that's why I definitely have a mix of those, but majority would just take one cream in relation to that. But really, I agree. Progesterone, estrogen, they can all be delivered intravaginally. And just to answer Dr. Quinn here, so do you check for pathogens such as protozoa, helminths, and worms? So the test that I showed here, I just didn't put the specific brand or the name of the test, that they do have that part of checking protozoa, helminths, and worms. And you'll be surprised that I see a lot of them being positive, especially for the ones who are like coming from international countries. But not only that, the ones who likes to camp out, the ones who just has like chronic. I had a patient who they thought that they had like Crohn's disease or even IBS, but once we checked it, it was actually a protozoa because they live in Mexico and the one in Peru, and we treated that IBS diagnosis was basically gone. So I do agree with that. So this is something that conventional testing would probably miss, because when they do the regular ova and stool parasites, some of these would not come out. But when you do these functional labs, though it's going to be heavier on their pocket, but definitely worth it for these patients who turns out positive, because now you can actually treat them directly.
I have a question, Dr. Nario.
Yes.
I noticed that probably you use the Dutch test to do the urine test that you do.
Dr. Halasa, can we mention?
Can we do that? Can we mention question, because I have a question about that.
About what? Is it commercial?
Well, no, he's asking
Yeah.
about he's putting out a brand name of the test.
Yeah, as long as we don't want any commercial because CME, but after the CME is ending, then you can have that conversation. For now, can you name the chemical or the generic, or the
Yeah,
chemical?
for me, I have tested them, or I used the urine test, I used all of that. And one company was doing the serum test for estrogen metabolites. And I found that serum test was actually more accurate than any of the saliva, the urine tests. And I tested all the urine tests, compared them with each other, and found out that the urine test definitely was not really appropriate, because there were several mistakes in those. I wonder what your experience
Okay,
is.
so here's the thing. Are you saying because the estrogen level in the blood is 10 times less than when in saliva or in the urine? So that needs to be in the consideration that it's not the same normal range. Is that the problem or something else?
That's a problem, but even in terms of the levels that they give us, the numbers are not quite accurate.
Well, here's the thing. You have to know that normal range of the urine is different from the blood, the normal range, and the saliva. Saliva and urine is almost similar, but the serum, it's 10 times less. That's mean the saliva is 10 times more. So as long as the lab is providing you the normal range, then you're good. But the other question is that what's important is the ratio. And that's what we want to emphasize on, which is the estrone to estradiol ratio has to be less than 2 as much as you can. And if it's more, then those estrogens are, as I said, carcinogenic, inflammatory, and they're metabolized. If you go through the lecture, they are all estrogens metabolites are causing the problems. And measuring the estrogen itself, which include all this harmful metabolites that's coming out from it, which I think Dr. Nario did mention them, but the ratio has to be less than 2 if you can get the estrogen and estradiol, and then the progesterone to estradiol for females has to be above 100. So the ratio is more important. I mean, normalizing the range is good, but that's not the complete answer. We also need to normalize the ratio. That's my
because what I was saying is even the lab that was doing the serum test, they want to be urine test, and when you do the urine test, sometimes it doesn't even pick up any of the estrogen metabolites like the 16 alpha, the 2-hydroxy. So you wonder what is going on with this stuff here.
So, Dr. Tano, I'm assuming that you're using this also in a sense of correlating your findings on your testing with the clinical picture.
Correct.
Is that correct?
Yes.
That's how you're verifying it?
That's how I'm verifying and see that this is not adding up.
Right, right. I'm pretty curious about that blood test. Maybe when we're off the record, what that is, because the majority of course, what we study or we teach in A4M, the only source that I know that produces metabolites would be a urine sample. So I don't know if this is a new company that produces.
No, that's one of the existing companies that they were doing it until May of 2021. Then they stopped. For some reason, they said they were not getting the reagents, and they haven't brought it back. I just complain about that all the time because I found that to be even over time to follow the patients. If we give them a DIM and paradoxically reduces the 2-hydroxy, you can see that. You can see, wow, but the DIM is doing a bad stuff to the estrogen metabolites.
Right, right. Yeah, to be honest with you, I have always been using urine from the start. But it would be nice to know this company that you're using, so we can also
I think after the lecture we can go ahead and learn that. But make sure the link for the CME that everybody here is contributing for getting your CME, or just donating for the organization. It's only $30 for 2 hours of credit. That's what I want to emphasize on. Any other questions for?
Yeah. So one other question I have for you: what do you put the phytoestrogens and the estrogen from fungus? Because for instance, wheat is contaminated with fusarium many times, and fusarium produces zearalenone. So if a person has already an estrogen overload and they're eating a lot of wheat products or all these grains that may be contaminated with zearalenone, how do you detox them? Do you take them off the phytoestrogens, or what do you do?
Yeah, so in that situation, so I am a user of a urine mycotox panel. I don't know if that's something that you're using along with this also to determine that. But I do consider ingested mold to actually be contributory to estrogen loads. But I usually determine that is adding another test to a test that is out of pocket via the estrogen metabolism test is another cost for my patient. So I determine that mostly from history. And if a patient is willing to pay for that extra mycotoxin test, sure, I'm very open to that. But if there is something that as part of the history that says that they are ingesting such, definitely the glutathiones, the liver detoxes like milk thistle. Of course, stopping the ingestion of the source would be number one. But adding all of these liver detoxification protocols is something that I always have done. But you would notice that when you promote glutathione pathways, methylation pathways, by trying to eliminate the 4-OH, also addresses some of these issues already. So it overlaps, but I do agree with you that there are cases that I've encountered that I needed to go that far.
Have you heard about PLG1? It's increasing fertility, and there are a lot of twins coming out from it. And I think it's managing polycystic ovarian syndrome. I mean, I am okay with PLG1 as long as they're doing it right, and it include multivitamins and antioxidants and the right nutrition, because it does have some oxidative stress that's happening in the pancreatic ducts. So you want to make sure that, and also the dose, you don't need to use high dose if you optimize the health along with using PLG1. But I think PLG1 is a great thing, because it does help to get rid from all this excess fat, along with the right detox and health optimization and the right hands. I'm okay with PLG1s. And I'm actually trying to formulate intranasal ones so the telemedicine doctors can prescribe it remotely. But there is big news now. The PLG1 is increasing the fertility in the United States, and a lot of polycystic ovarian women are having babies. Have you heard about it? It's just recently in the news.
Yeah, I have seen it, but not only through women's health, but you would see the uprise of GLP-1s lately. That even now the cardiovascular benefits are being acknowledged by our conventional colleagues here in using GLP-1s. But in my experience, it's really by default. As you lose all this inflammatory adipose tissue, I have seen so many things corrected. It starts with the cardiovascular, it starts with the endocrine, which is, of course, the intended purpose of it is to lower down diabetes. And you mentioned about PCOS. That's something that I also use with those patients. And it's just a domino effect of good things. And right now, with what you're saying, improving fertility, for me, it's pretty obvious that when you remove all these inflammagens in your system, all of these hormonal dysfunctions will now correct itself. But I haven't used it. I don't have a patient who got corrected in relation to their infertility, but I have heard of your update about GLP-1s.
Yeah,
So
I think it can
happens
be
to the
done.
pancreatic duct?
Yeah, there is some stress that happen on pancreatic duct. It stimulates the pancreatic growth, and it leads to pancreatic obstruction, and that leads to pancreatitis. But if you health optimize, you're making sure your carotenoids level is normalized and vitamin D is normalized, and you balance the sex hormones as well, so that all this proliferative effect of estrogens is being normalized or neutralized by progesterone and iodine, then you're okay with
No, but
using
what causes the pancreatic duct hyperplasia?
Ozempic itself. PLG1, it does have proliferation effect on pancreatic ducts, so it's increased the growth of the.
I've been using it. I have not seen it.
There is some cases that they end up in the ICU with pancreatitis due to obstruction of pancreatic duct. But those cases, most of the time, the doctors are just shooting the PLG1 without health optimization. You will not see it if you're integrative doctors and you're taking care of your patients. I don't think you can see that.
The selection of the patient is very important. You just cannot.
Right. So as long as you're following up with health optimization, you're okay. So as integrative doctor, I don't think you will see those cases. But those candy shop doctors who are just injecting PLG1 without checking the patient, without detoxing, without normalizing their metabolism, they will have some incidents of people with acute pancreatitis.
How often have you seen that GLP-1 stops working and you have to move on to the terpesitide?
There is a percentage there, and there's actually right now a genetic testing to know whether this patient is responding, or this patient will have side effects, or this patient will not have response. And that's what we are going to develop with hopefully with research and development. So that's something we want to do.
So
Dr.
who
Patel,
does that genetic testing?
Right now, it's still in, I think, R&D, not yet finalized as a product, but I am engaged in those lab recently. So
question for Dr. Nario
Yes.
about that. I've been using progesterone for some ladies, those who are unable to sleep. And I'm talking about in the 80s, okay? And sometime 100 works, but then 100 stops working. Then you increase to 150, 200. And then there is a some that they have to take higher dose, but then they take it at 10 o'clock and then they are able to sleep without any trouble. But the next day, there is a complaint that they feel like they have a sedative effect. So, so what do you do to counteract that sedative effect? Because they don't want to change the dose. They say they
Right.
don't want to change the dose because when they change the dose, then it doesn't work and they have to go and use the higher dose. So,
Right.
what is the mechanism in all this?
So it's really in relation to progesterone, you're creating the alloprogenidiol, so or alloprogesterone when it passes through the liver. The thing is, and that of course goes into the brain to act as a GABA stimulatory effect to the brain cells. The thing that I do with this is I have patients who had actually experienced this. What I do for the ones who does not want to lower the dose, I actually, so this is something that I've learned from my pharmacist, and also it's probably known to you as well that extended release versus immediate release. So that's something that I shift patients towards too, because sometimes if the extended release, which I always go for patients who can pay, does feel this effect, that extended sedation that they would feel in the morning. And when I move them to immediate release, that problem kind of lowers down. But again, everybody's different. Sometimes it doesn't work. And I really have to kind of titrate it down to, let's say I negotiate to 175. And again, that's only going to be done in a compounding pharmacy. But that's a strategy that I have done before, which
So the most of the what is available in the store, conventional pharmacies, are they long acting? I thought that
no.
they were micronized normal acting, right?
Right. So this is, yeah, this is something that I was actually was not divulged to me later, that the ones that you get from CVS, Walgreens, oh, sorry, or these regular pharmacies are immediate release. When you go to compounding pharmacies, that's when you can actually request for extended release. So it's something that's why it's compounded, because usually a patient needs to fail first conventional therapy, and the pharmacist can document that the conventional type of progesterone, even though bioidentical, had failed, and now your compounding pharmacist can make it for you.
What are the indications for using the extended release?
So for extended release, these are the ones that I use on patients who has issues with, one, initiating sleep, and number two, who wakes up in the middle of the night. So when you would notice that it can actually bring them towards up to longer hours of sleep versus an immediate release that only helps them with the initiation of sleep. And again, if they don't have these issues of waking up in the later parts of the night, then you can consider that. So it's really the length and duration of a
She is not
specific.
using any extended release because, when you buy from the conventional pharmacies, they are just giving 100 milligram dose or 200 milligram dose.
Right,
And then
right.
if you have to add, subtract, you give them the compounding pharmacy, and
Correct.
they make the liquid so that they can adjust their dose.
So,
So
Dr. Patel, have you used the topical progesterone? Because I have used topical progesterone for years, and it does the same effect. It doesn't cause overly sleepy people, but they sleep really well, and that's one of the good benefit of it. So I don't know.
that's a good idea. I mean, I do use topical, but not for this particular patient because she's so sensitive, so I want to avoid any kind of chemical that and transdermal does have certain degree of other
That's correct.
ingredients.
So that's correct, because the base that many of the compounding pharmacies use contain estrogen. Many people don't realize that. So when women
What,
say-
progesterone has estrogen in it?
No. Yeah, but when they're compounded, they buy the base from pieces, some of the major sources, and those contain estrogen compounds in them. So in essence, if you say, okay, I'm giving you progesterone topical, you're giving basically progesterone and estrogen compound to this patient, and the
No, I give them oral. Progesterone I never give topical, except the topical preparation we do get, and initially in perimenopausal period it works really great. So we use for that, but most of the time my estrogen is the only topical and progesterone is oral. But I thought that sedative effect on the following day, are there any antidote for that?
So,
mean-
so let me go ahead with sedative effect. As Dr. Nario said, it's a GABA pentin effect of progesterone. It may prolong. So I think what you need to do is just oxytocin intranasal in the morning along with B12, and that will wake the hell out of them. They will be actively and doing good. Oxytocin and B12 nasal spray. That will wake them
in the morning.
in the morning. Yes, that will wake them up. But that's the reason we don't recommend oxytocin at night. I
No,
think Dr.
yeah.
Joseph James will confirm that too. We like to give oxytocin and
Oh.
B12 in the morning.
Yeah, I
and then
use
at night.
oxytocin, but I never thought that it would work for this sedative effect. So well, I told her to drink the hot water and put certain things, but I
B12 and oxytocin together,
yeah,
right?
yeah,
Dr. Joseph, are you
that's
there?
that's a nice one. And there are times that her progesterone stops working at all. And then we have to look for some other and the GABA, if you use any GABA, it doesn't work on her. So I
Dr.
mean, we
Patel,
just say that it works through the GABA receptors, but when you use GABA itself, it doesn't work.
another strategy that you can probably, because you're saying that you're using basically immediate release on her, and she's still sedated. That's how I kind of analyze your case. You can definitely try now. You can go back to your compounding pharmacy and ask them for maybe 175 milligrams immediate release. So you would see that if she's amenable for at least lowering it to 25 milligrams, but now you have to go through a compounding pharmacy because that is not a commercially available dose that's out there.
But the commercial available dose is immediate acting, right?
It's immediate acting, yeah. But if you don't have anything that's commercially now, compounding will have the ability to make one for you.
The
And
compounding is making her immediate release. So like if she is taking 225, then 100 she takes commercial, and then 25 she takes compounding.
oh, sure, okay. I mean, you can play around with that too. That is possible.
Yeah, the only
Uh,
thing I
Yeah, I mean,
think is
when
oxytocin
I
and
put her
B12.
on ARA, I had to do the skin testing on her and find the precise dose for her. And then I'm treating her with that dose, and that dose works wonderful. But if
mhm.
I give her the regular, then she's full of symptoms and doesn't work. So this is the kind of patient she is.
Right. And with Dr. Tano's suggestion also, even though on literature, the more potent form of progesterone that actually crosses sedation is oral, I do have patients who actually tells me that even on topical, they do get sedation effects with
You will
progesterone.
get more effect intranasal form. I recommend intranasal over oral and topical.
What for progesterone?
Yes.
Yes.
Progesterone intranasal, it's way better than both forms, especially if it's complex with cyclodextrin. You get the immediate release, plus there's some long effect because progesterone will.
But cyclodextrin, how do I know that she will not react to?
Well, there
Dr.
is.
Halasa,
Yeah.
she's a one in a, I mean, she's one of, out of my 50 years of practice, she's
You
one of
can
my,
apply the cyclodextrin cream on her hand, and if she react to it, then she doesn't need it. But it's a very topical delivery too, and it's the best delivery right now in the market. Plus, it leads to detox. So you're doing
So
you're
the
using
nasal
it.
spray, why do you need to put the cyclodextrin in the nasal spray?
Well, that's what they do with eye drops. Do you know eye drops?
I know they do, but why do we need to put it if we can avoid it?
It helps in the absorption. This is one. It also helps in keeping it from being going everywhere. In other words, it just helps to change the pharmacokinetics. Yes, it does cause instant release, and also it has extended release at the same time because you're getting into the brain directly with intranasal, and you can use less dose than others. And but that waking up in the morning, that's so easy. Just B12, right? 1 milligram nasal spray per mil, just, and then oxytocin. I mean, Dr. Joseph James, you have a lot of patients, B12 and oxytocin, they cannot sleep at night when they do it at night. And so they do it at morning, and they feel fresh and awake.
And what do you give at night for sleep? Let's say if progesterone doesn't work, what else would you use?
Well, you need to find out the patient's conditions, and if it's all optimized, we need to find the reason why. Progesterone will be the best option. I mean, I will not go with giving her anything that's
She's the
governed.
most allergic patient, okay? She's the most allergic patient.
Right, right.
And we have to rotate her food, give her food injections, everything you learn, everything she has. But she
What
and
about
she,
giving
she was a professor, so
pregnenolone?
she's very smart lady.
What about
And
pregnenolone? Pregnenolone instead of progesterone.
yeah, that's why I gave her progesterone. It works, but when progesterone will stop working, I don't know what else to try on.
Pregnenolone.
Pregnenolone.
Yeah, pregnenolone, which is before the progesterone.
That you would I know that you would give as what? As a nasal spray or as a capsule?
I
or
think
what?
what's available it's oral, but you can ask the compounding pharmacy to do it intranasal. Yes, it can be done. Maybe she has a problem with
Is
conversion.
it water soluble?
You use cyclodextrin to to stabilize anything.
Cyclodextrin.
Yeah, cyclodextrin. Yes. Cyclodextrin is going to be a big thing. Big pharma is moving to all the drugs.
So
right
what happened to you were telling about that it increases the HDL, but we never heard
Not
from you.
increasing the HDL. It works like high density lipoprotein. It's a complex similar to it cleans up the extra fat tissue and fat soluble toxins and endocrine disruptive and
What dose do you use?
I mean, it's used with the drug, so it's a complex most of the time. We don't use it nakedly. You got my point?
So you don't give a capsule of that cyclodextrin. That's what you're saying?
Yeah, most of the time I would prefer adding it with the drug, and maybe the ratio is going to be 1-to-1. Let's say if you do this is what my proposal for intranasal progesterone. Let's say you can do, or let's say intranasal PLG1, the PLG1.
Yeah.
So I recommend 30 milligram PLG1 inside a vial and 10 milligram of naltrexone. That's for weight loss. And then I think we adding
GLP-1.
GLP-1, naltrexone, intranasal.
So cyclodextrin, where do you get the wholesale?
Oh, I think he got cut off. Dr. Patel, this reminds me of a case that I have, because I take care of CIRS patients, and I treat them with the shoemaker protocol. And with the patients that I encounter with this, we have a method called low dose VIP. But this is something that I would probably test first and confirm if the patient
I have a VIP, but I'm just I mean, if it has worked on your patient, I can try, but I have to skin test her.
Right, that also is another one. But we're talking about like a dilution of like 1 to 1,000. So yeah, it's a VIP version that there's only one lab that does it that I know of that customizes VIP in the lowest dose that you possibly can give it. So that's something that unless
Have
yeah,
you used it? Have you used the VIP? What is
yes, I
the
have.
what is the concentration for 1 ml?
The one that I write for the pharmacy, I think it's a 1 in 1,000. That's how
1 to 1,000?
yeah, that's a micro dosing of VIP
Yeah,
for
so 1 to
sensitive.
1,000 we can make. Yeah, no problem.
Mhm. Okay,
1 to
so
1,000 we can make. That is dilution number 5.
as a nasal spray, right?
Yeah, yeah. What you do is take 1 ml of concentrate and just keep on diluting, and then it will be like 1 cc will make 100, and another dilution will be 1,000.
Okay, so if that's something that you can try, but I would investigate about
But
CIRS here.
what I have not seen, I have used VIP, but I have
Mhm.
really not seen uh like what you see with ARA or TA1 or TB4 or KPV.
Um,
I have not seen that kind of effect with VIP.
right. So when we use
And I
VIP,
think Dr. Shoemaker got in trouble for using VIP. So now he's suggesting to use the much more diluted dose so that becomes more like a homeopathic dose.
yeah, almost. But again, that's for the sensitive patients. But when
Yeah.
you get into the non-sensitive patients, you go back to the regular dosing again. But majority of VIPs, why it does not work with these biotoxin illness patients is because we have not lowered down the inflammatory markers like TGF beta 1, VEGF, MMP9. So all of these needs to be all normal before you go into that regular dosing of VIP.
How often do you think that you have gone down to TGF beta 1 and MSH or the MMP9? How often have you seen those numbers going down? I mean,
Corrected.
in my practice, I would say that if I treat 100 of them, maybe barely 5 of them have that number.
Oh,
And
so
it
that
doesn't stay. It doesn't stay that number when you do it every 3 months, just to check it.
right. So in the protocol, we actually, as mentioned by CDMPS already, that losartan is something that you use for TGF beta 1. And for the VEGF MMP9, I use high doses of omega fish oils. But
Yeah.
always with the biotoxin protocol, you have to make sure that these patients are removed from exposure because all of these numbers are always going to go up. You thinking that it's all going down and they're healing, suddenly they go up again. You'll find out in the history that they got re-exposed again to such. So I do see a lot of them normalize. That's why it's all about just finding out what's causing the increase in these patients. So, but and also to go back to your question a while ago about if you're seeing a lot of semaglutides going into the tirzepatide because it's building
Yeah.
antibodies.
Yeah.
One who's pretty verbal about this is Dr. Clearfield. So he always mentioned this in his talks that it worked for him initially for semaglutide, and then tirzepatide actually he used it and eventually didn't work again. So there are patients that I have seen also. I just mentioned him to you because you know him, and he's again, I'm not breaking hip, but he's open about this, and he
Right.
talks a lot about this in his lectures. And also for your question about why is there pancreatitis when you use GLP-1s, for the reason that the exocrine ducts of the pancreatic cells actually has GLP-1 receptors. And the overstimulation, of course, if you're using a lot of GLP-1s, causes overgrowth and hyperplasia in these small ducts, and thus now, of course, blocking the duct excretion of these exocrine hormones are digested or enzymes, pancreatic enzymes, thus I guess, digesting the pancreas. So that's the reason why GLP-1s are known to create pancreatitis.
Have you read any report that it causes more of a pancreatic cyst?
No, I haven't read of. I know thyroid complications, but not pancreatic growths. Maybe. I mean, as you all know, GLP-1s are pretty early in its stage. Um, we have no experience in pancreatic cysts and GLP-1s.
Thanks, Dr. Nario.
Yeah, you're welcome.
It's after what you discuss is sometimes very more acknowledging, you know.
I know. Well, thank you, Dr. Patel. It's nice seeing you again.
And you mentioned something about using DIM, and that slide went by a little too fast. So
Oh, you want to see it?
I mean, I use DIM on all my patients when I prescribe them
Mhm.
the HRT. So
Right.
so so you had some comments there about, okay, it's here.
Yeah, because you would notice here on this slide that when you use DIM and also the literature here, it says increases the significant increases in the level of CYP1B1. So 1A1 is the good one, right? So we like
Yeah.
that. But when you use DIM prematurely, you will also promote this pathway right here. That's why the rule here is fix phases 3, 2, 1 initially, because you will, if you use DIM, you will divert them toward methylation detox and also glutathione detox. So
Right.
if you're probably gonna be heads up doing DIM, make sure they're probably on NAC or glutathione
Right.
or magnesium or methylated Bs at the same time.
Yeah.
So
Yeah.
it's okay to use them, but at least have these two pathways open up or
Yeah.
utilized.
You have to use the methylated B, and I
Right.
mean, all that. And we also use the calcium diglucarate, because glucuronidation is sometimes compromised.
That's correct.
So, and not to use too much, because then you bind it and then it goes in fast forward, and then you do not have a good optimal effect that what you desired. So
Mm-hmm.
but the DIM, are you giving twice a day or once a day?
I have done twice a day for that. Once
Yeah.
I'm pretty confident that the detox pathways are pretty open and cleaned up. If
So
I'm pretty
when do you
conservative
start
with
them
it.
on a DIM? On your journey when you're doing the
Oh, okay. So I usually use it at the latter part because I have a lot of colleagues and practitioners that use it at the get-go, at the beginning. So I want to make sure that I build up the Bs first, the glutathiones, the NACs, and then maybe after a month or two, then if I see the clinical symptomatology of the patient improve and change, then I can tell that I don't need to do another retest of the urine metabolites. It's pretty expensive. So I
yeah.
base my decision making on clinical responses. Then I insert my DIM or I3C after that duration as an average.
So then do you use that also in your cancer patients? When breast cancer patient comes to you after their typical conventional treatment, and then comes to you for the integrative treatment, then where do you start and what do you start?
Right. So it depends. So when we're seeing them fresh from therapy, we definitely, because I don't know if you remember, I have mentioned before that we used, I don't know if you're familiar with the Greek test or the RGCC test.
Yeah, sure.
Right.
I use that all the time.
Okay. So that will give you actually a good idea about using I3C on the supplement list there. So if that
Yeah,
shows up,
it has a list. Yeah.
right, if that shows up, we don't do the urine metabolism test anymore because we're fighting directly cancer and they can use it directly for that. But when they're post therapy, where we're talking about rebalancing hormones again, that's when we definitely want to see again a new urine metabolism test. So again, now we're mixing two different testing patterns.
But
But
when they come and tell you that they're tamoxifen and they're oncologist doesn't want them to go off the tamoxifen. So what
Mhm.
do you do then?
So if the Greek test does shows us that it's high on their number, then we definitely just use it and make it part of their protocol.
Okay, so you use absolute Greek test. Okay.
Yes. Mm-hmm.
And what about for prostate? You were just showing about prostate. You were talking about the estrogen and
Mhm.
testosterone, but I'm not too sure that what h- how do you apply our knowledge to a prostate cancer?
So with prostate cancer, I mean, obviously that already is a show of a high 4OH in a male. And when you want to consider DIM or I3C for that, you still apply the same concepts of cleaning fixing 3-2-1 metabolism for it. But when I pointed out that example is I don't only use the urine metabolism test for women, but also on men, there's also an application for it. And this is how you would see BPH and even prostate cancer would benefit from this test.
And where do you find that? I think in the test that we order from Dutch test, they do mention about the genetic that SIP1B1 gene and SIP. They don't.
Yeah,
Yeah,
they
I
do.
thought that I read that it was there.
Yes. So when you request, so you fill up a form, a requisition form, you would just indicate it's a male sample. So it's also going to present the same, but some few variations to it. But once you indicate it's a male sample, they'll now give you the male format of that test.
And do you, when you are doing for the cancer patients, do you also order the cortisol panel or you don't?
Yes, definitely. Very important. Because as we all know, low cortisol curves, like flat cortisol curves, are more prone on studies to have remission, exacerbation of their cancers, and even building more cancers and other comorbidities with a flat cortisol curve. So it's an always a must for us that we do it.
So where do you maintain that?
What company?
No, no, no. What I'm saying is when you
Mm.
when you order the test,
Uh, oh, when do we order it? Hello?
did you follow what I'm saying?
No, could you repeat again? You got cut
Yeah.
off.
What I'm saying is when you order the cortisol panel
Mhm.
in a cancer patient, where do you try to manipulate and what level you try to maintain it?
Oh, so of course, ideally you want it to be in the middle of the, isn't it? There's a
Yeah,
low line,
yeah,
a high line.
right.
You want it back in the middle as much as you can. But these are pretty long therapies. As I noticed, it takes me what, 6, 7, 8 months to get these cortisol curves back into place. Just because these, you have to understand, these are patients who are going through a lot of stress. Not only we're talking about past stress that they have incurred, but also the ongoing cancer stress that they're going through in relation to their therapies. So this is basically an ongoing therapy, regardless of whatever stage they are in their cancer journey.
But they would be high on the high end of the test, not low end, right?
Most of the time, they do present differently. In my end, you would notice that, let's say, majority of these patients who had gone through, let's say, multiple rounds of chemotherapy, recurrence, remission, I see them really drained out and see their curves more on the lower side of things.
Oh,
For the newer ones, I see them newer diagnosed ones. I see them riding higher on the cortisol curves. But again, not always. It's just the majority that I see.
so when they have a low, then you give them Cortef or what?
We try first the non-steroid related therapies, of course, your licorice, adrenal extracts. You go for the typical adaptogens to raise it up again. Is hydrocortisone always kind of like a last resort on our end? But we have resorted to that in these cases that has not responded with these natural therapies. And it's effective. The hard part with that, it was the weaning part. That once they got their bearings back, hydrocortisone needed to be tapered off, and you would notice that these patients who were so dependent on this, who've used it for a long time, would say, "Hey, I don't feel right when you lowered my dose." So now we have to titrate it back again, and do it slowly. And when we do titration meaning when we taper off patients, I always make sure that I put an adrenal extract in there, regardless of whatever dose they are. So it kind of dampens the hits of lowering down the doses of hydrocortisone.
Oh, that was very nice. Thank you.
Yeah.
And if they have a high, what do you use that?
The high ones, those are the common ones that we always hear, the ashwagandhas, rhodiola,
Right.
magnolia, right? Cordyceps, ginseng. So, I mean, for me, really higher is, I don't want to say easier to manage, but it's just, I would rather have higher because I know the adrenal glands are still working. Because when you have lower curves, you know that adrenal term fatigue, which is not really the term now, is harder to recover. So, I mean, your pick right now for everybody who do a test is either high or low. I don't see I rarely see normal curves nowadays.
Yeah, it's
It's a
but
harsh
I
world
think
out there.
I also manage clinically because
Yeah,
what their norms are, just like other labs. Their norms are going to be um, depending upon their lab population.
right, right. I agree with that. There's not a lot of people who can afford
Yeah,
the salivary cortisol test. So
right.
you just kind of wing it in relation to clinical symptoms.
But we have, I mean, if you use some anti-inflammatory peptides, sometime that helps to bring them low because then they don't have a higher degree of stress of inflammation.
All right. What peptides do you usually use to control cortisol?
I'm sorry, what?
What type of peptides do you use to control cortisol?
Well, I mean, depending upon like for uh, for cancer patients, I use usually TA1.
TA1, yeah.
I
That's
tier
another
one.
one.
I use tier one, and then sometimes you have to use KPV or ARA. I have used a lot of ARA.
Yeah, KPV is good. It's an MSH derivative.
Yeah,
So that definitely has a control on the ACTH. And I think I have not used this, but I've been trying it now. Epitalin. So it's a hypothalamic type
yeah.
of
You have a
peptide.
good results with Epitalon. I used
Um,
them and I didn't see much difference, so I stopped using it.
Yeah, well, epitalin, when you use it, it's actually more of a longer acting type of peptide. So it's something that you should probably expect results after chronic use. It's not really that quick type like of BPC effect in terms of repairing tendons and ligaments. That's why you really have to be patient. And it's called the anti-aging peptide because it's even lengthening telomeres. So that's why, again, with cancer, I don't know if you want to use that there. I'm just talking about regular stressed out
Yeah.
individuals. Just because of that,
And
it's
even if you use TA1 and patient goes to an oncologist, you don't have a problem because so many trials have been done
right,
with the use of TA1 along with giving them the chemo and immunotherapy and the IV
right.
TA1. So I mean, you feel very comfortable in use of that.
Yeah, and I use it in so many different situations.
The
I mean,
only thing that
right?
I have not found yet something that increases the total lymphocyte count and like yeah, so many times their CD8 is low
Mm-hmm.
and their CD4 CD8 count, if you look at it, its ratio is very high uh,
Mm-hmm.
because CD8 is low and I haven't found yet yeah, you reduce their total toxic chemical load. But these patients, those who come to us, after they have multiple rounds of uh, chemo, so they wipe them out, and then they are coming to us, and it's
Right.
very hard to bring their lymphocyte count up.
One
So
thing that we have used, you can definitely try this, pretty safe. And we found this in NK cells that to increase it is IP6. So
which one,
inositol,
lymphocytes or just the NK cells?
NK, just specifically NK. So you can definitely try that if you're having an issue. But the other ones, I've heard anecdotally, of course, TA1, but you're not seeing that, as you said, you've been using it on your patients and you're not seeing the increase. But
Yeah.
NK cells, yeah, IP6 is something that we've used before.
So what dose of IP6 you use?
That's a good question. We have one. I'm not familiar with
What
this.
brand are you using? What brand of the drug?
I think it's pure encapsulations that
Oh,
that we're
okay.
using.
Yeah.
Yeah. So try that out and see. I know
Yeah.
you see a lot of cancer
No,
patients.
I use the multi-immune. So multi-immune by research
Research nutritionals.
nutritionals. Yeah.
Oh,
And
okay.
and their multi-immune is supposed to increase the natural killer cells, and they have done so much work, and there's a supporting data.
Oh,
So
nice.
so it is better to see the supporting data, because they're being used for a lot of different kind of viral infections.
Interesting.
Dr. Joseph was saying that there are a lot of viral infections, and that this in earlier days they used to call stealth infection. So
Right.
so I think that is something that can be used.
Yeah, I have heard of that product, and because they promoting that for like Lyme, right?
Or you can use
Secondary
for as
infections.
a supporting factor, but not for Lyme. They have a separate product. For EBV, they have separate product. For Mycoplasma, they have separate product. But this
Right.
is you can use with any of those other products.
Yeah, and I've known of them. They're pretty good.
Yeah, that was nice. I'm sorry we are boring somebody else, but
It's okay.